Hello friends, intravenous thrombolytic therapy is the only proven treatment for acute ischemic stroke, but its use is limited by a brief time window of up to 4.5 hours after the onset of symptoms of stroke. And IV thrombolysis is associated with poor recanalization rate of affected artery in the brain. It is less than 50% of recanalization rate. If given in mobile stroke unit, recanalization rate may improve. Moreover, such patients remain disabled with less than 30% achieve full functional independence after 90 days or 6 months. So this is the main issue. Less than 30% of the patients after IV thrombolysis achieve full functional independence. That is quite poor. Moreover, large clots in the large vessel like distal internal carotid artery or the first segment of middle cerebral artery respond poorly to intravenous thrombolysis. Therefore, mechanical thrombectomy is a groundbreaking intervention for such such stroke patients caused by large vessel occlusion. Last decade has seen major trials conducted in thrombectomy which consolidated its efficacy and safety. So they have now the efficacy and safety of thrombectomy has been proven very well in last 10 years, especially at the advent of 2015. So we are going to discuss all the trials in this presentation. So these trials can be divided into two parts: the anterior cerebral circulation trials and the posterior circulation trials. Okay, so we have about 5 trials conducted in the stroke patients affected by the anterior circulation thrombosis. Then we have posterior circulation stroke trials also. Only 2 major trials have been conducted. So now we will discuss trials related to anterior circulation. So the first trial, which is the largest one among all the trials conducted in thrombectomy section, is the MR Clean trial, which was a multi-center study involving 500 patients from the Netherlands. It demonstrated that intra-arterial treatment administered within 6 hours of stroke onset is effective. Patients with acute ischemic stroke due to proximal intracranial arterial occlusion were randomly assigned to intra-arterial treatment versus usual care. Okay, the primary outcome was the modified Rankin score of 0 to 2, that is functional independence. So modified Rankin score from 0 to 2 is otherwise termed as the functional independence. These patients can be completely independent. Okay, they can do their job, daily routine. So this is our primary outcome, and it was found that the primary outcome was quite different, quite better in case of thrombectomy. So in interventional group, the rate of functional independence was 32.6% compared to that in control group, which was only 19. Now another significant trial is the ESCAPE trial, extracranial intracranial trial, an open label RCT published in NEJM, which involved about 315 patients from 22 centers across Canada, United States, South Korea, Ireland and UK. Patients with acute ischemic stroke, a small infarct code, proximal intracranial occlusion in the anterior circulation and moderate to good collateral circulation were randomized to receive either standard care or endovascular therapy in the form of thrombectomy. And they found significant increase in the rate of functional independence, that is 90-day modified Rankin score of 0 to 2, okay, compared to control groups. The rate was quite good, encouraging, 53% versus 29.3% in the control group. And the rates of hemorrhage, the significant intracranial hemorrhage rates were very not different in control versus interventional group. So this is the graph taken from this NEJM paper. Okay, so modified Rankin score 0 to 2. So in control group it is just less compared to intervention group, which was quite high, 53% compared to 29.3%. Then we have extend IA study. This is the third notable trial. However, this is the smallest trial among all the thrombectomy studies for stroke conducted at 14 centers in Australia and New Zealand, and it involved only 70 patients. Okay, so these patients were randomized to receive either alteplase plus thrombectomy or alteplase alone, and trial found that endovascular therapy was significantly improved, associated with the improved reperfusion rates. So this first box plot here shows the reperfusion rates. So the reperfusion rates were quite different: 100% versus 37%. 100% in the thrombectomy group, 37% in the alteplase group. So this is quite different and quite encouraging. And also there was noted early neurological improvement, 80% versus 37%. Additionally, 71% of patients in the thrombectomy group showed functional independence, okay, compared to control group, where it was very less. Now we will talk about an Spanish trial called Revascat trial, which is again another important study from Spain. Evaluated the efficacy and safety of thrombectomy within 8 hours of symptom onset for acute ischemic stroke. 208 patients were randomly assigned to receive either medical therapy alone or medical therapy plus endovascular therapy, that was thrombectomy group. So the primary outcome was again the functional independence rates, modified Rankin score of 0 to 2 at 90 days, which was observed to be very high in thrombectomy group, about 43.7, or you can say 44%, compared to control group, about 28%. Okay, so this trial was again a positive trial showing the marked improvement in the functional independence rates. Okay, so this is, and one more thing is, at 90 days the rates of symptomatic intracranial hemorrhage were only 1.9% in both groups. There was no difference at all. Saif Prime trial was published in an EGM involving 196 patients randomized to receive either alteplase or alteplase plus endovascular thrombectomy within 6 hours of symptoms onset, and this trial was also positive in terms of the functional independence rate, which was the primary outcome. It showed very high rates, about 60% compared to 35% in the standard control group. Okay, so this is quite significantly different. And the symptomatic intracranial hemorrhage was also not different in the groups examined, 0% versus 3%. So if we compare the trials in the anterior circulation thrombectomy, it shows that MR-Clean or Mr. Clean trial was largest trial, while Extend IA trial was the smallest. So largest trial was MR-Clean trial, which had 500 participants, the largest trial, compared to Extend IA trial, which took only 70 patients. Okay, the best outcomes were reported by Extend IA trial. Okay, because if you look at the functional independence rate, which was quite exceedingly high, 71%, compared to the lowest was observed in MR-Clean trial, 32.6%. Okay, an ESCAPE trial had the longest maximum time from stroke onset to randomization, 12 hours, compared to all others. So these are small points you should remember. These are intricate points, important points. So ESCAPE trial had the longest maximum stroke onset to randomization time of about 12 hours. However, despite allowing enrollment up to 12 hours in ESCAPE trial, if you look into study, it showed that actually the median time was less, up to just 241 minutes. That is up to, you can say, 4 to 5 hours. Okay, and only 15.5% patient randomized to more than 6 hours of stroke onset to randomization time. So basically they could randomize the patient within maximum to maximum 6 hours, but median time was just 3 hours. So this is important, 5 to 6 hours. So this is important. No patient was randomized after 6 to 7 hours. So this study was not powered to assess the endovascular therapy for patient presenting 6 to 12 hours after symptom onset. There was no study. Okay, and the Mr. Clean trial reported lower rates of functional independence compared to later trial due to several other factors. It could be The patient selection, as we have noticed that Mr. Clean trial treated patient with large vessel blockage within 6 hours of symptom onset, but its patient selection criteria were less stringent compared to later trials like Dawn or Diffuse 3, which used advanced imaging to identify patients more likely to benefit from treatment. Imaging techniques also can be a factor in improving the functional status with thrombectomy, because with imaging we could see the salvageable brain tissue. Okay, so we can actually select narrowly the patients who will benefit from thrombectomy based on salvageable brain tissue volume. Okay, so that could also be the reason why later trials showed better outcomes compared to prior trials. Okay, so this could be difference. This could be important points regarding the trials conducted in thrombectomy. Now we will talk about the trials which were related to or which assessed the efficacy of thrombectomy in posterior circulation. Okay, so there have been only two trials, basics trial and attention trial. So we'll talk about basics. So basics is basically basilar artery international cooperation study trial, evaluated thrombectomy efficacy and safety in 300 patients with acute ischemic stroke due to basilar artery occlusion, treated within 6 hours of symptoms onset. So what were the main results? So again, the main results were improvement in the functional outcomes, modified Rankin score 0 to 3. So they did not use 0 to 2, they used the Rankin score 0 to 3 at 90 days as the primary outcome, and they showed that the primary outcome was favorable with the thrombectomy group, 44.2% compared to 37.7% medical group. However, this was not statistically significant. So basics trial showed no significant improvement in the functional outcomes with thrombectomy. So that you have to remember. And this was done within 6 hours of symptoms onset. Attention trial was published in 2022, randomized 340 patients with acute ischemic stroke due to basilar artery occlusion, again treated with 12 hours of symptom onset. And this trial found that endovascular therapy was associated with significant improvement in functional outcomes, 46% versus 23%. Okay, so if you compare these two trials, you will find that the rates of favorable outcomes, that is modified Rankin score 0 to 3 at 90 days, were similar in thrombectomy group. So 44.2% and 46% in both trial in the thrombectomy group. Okay, but if you look at the control arm, there is a large difference in the favorable outcome. So this discrepancy may stem from differing thrombolysis rates in the control groups. About 1/3 patients in attention trial received intravenous thrombolysis, while around 80% did in basics trial. Okay, so there is a huge difference in the thrombolysis rates, which could be due to basics requiring all patients to be eligible for thrombolysis during the first 4 hours of recruitment, and its 6 hours window period for thrombolysis compared to 12-hour window period in attention trial. Okay, so this could be the reason why you could see better functional outcome in the control arm of basics trial. So if you could understand that, that will be very good. Otherwise, this is the table for you to look into more, importantly, more closely. All right. Now we will talk about endovascular thrombectomy, whether this is effective beyond 6 hours. As you know, it is all the trials have shown that within 6 hours it is very effective after a stroke onset in the large vessel occlusion. But questions arose regarding its benefit beyond this window period of 6 hours, leading to conduction of two pivotal trials, Dawn trial and Diffuse 3 trials. So these two trials were done in taking into factor that maybe thrombectomy is useful after 6 hours. So Dawn trial was conducted in patients who presented between 6 to 24 hours of symptom onset. So what they used was the clinical deficit and infarct volume on imaging. with this mismatch to select the patient, and they they recruited 206 patients. They randomized these patients to receive either thrombectomy alongside medical therapy versus only medical therapy, and they showed that thrombectomy improved the functional outcome. So the median MRS score was 5.5 compared to 3.4 in the control group, resulting in adjusted difference of 2 points. And if you look at the percentage of functional independence, so it was 49% in the thrombectomy group and 13% in the control group. So there was a significant functional improvement. So DAWN trial was positive trial. Okay, now next trial is diffuse 3 trial. The diffuse 3 trial focused on thrombectomy effectiveness from 6 to 16 hours. DAWN trial was 6 to 24 hours. This is 6 to 16 hours, little narrower and earlier. And a patient was selected based on perfusion imaging. Out of 182 patients, those receiving endovascular therapy plus medical treatment experienced a favorable shift in functional outcomes with an odds ratio of improvement of 2.77. So about 45% of patients with endovascular therapy achieved functional independence compared to 17% in the control group. Okay, so that's all for today. Thank you so much. Tune in for more videos like this and subscribe to my channel. Next video will be on trials related to medical therapy in stroke.